I'm Bill Bro, and this is Kidney Cancer News. According to an article published recently in the Mail Online, Japanese scientists have created cells capable of killing cancer for the first time. The article says this dramatic breakthrough was made by researchers in Japan who created cancer-specific killer T cells. The next step will be to test whether these cells can selectively kill tumor cells but not other cells in the human body. The findings were published in the journal Cell Stem Cell. MedWire News reporter Sarah Guy says U.S. researchers have reported the success and feasibility of a novel method of carrying out partial nephrectomy in kidney patients using minimally invasive surgery. This procedure involves injecting ice slush into the kidney through a gel point access port. In all, 7 individuals formed the study cohort. No patients experienced a drop in core body temperature of more than half a degree centigrade, and the 1-month minimum follow-up data indicate no postoperative complications.
I would like to start this presentation thanking the scientific committee for this kind invitation for the Saturn project on behalf of all the members of Saturn project. I am the coordinator of this Italian project together with Nicola Longo and Alchiede Simonato, and this is a multi-center retrospective national study including data coming from 16 referral Italian centers, and we included in this databases all the patients who underwent partial or radical nephrectomy for localized or advanced RCC in the period between 1995 and 2007, and we performed for all cases the follow-up in 2009, and at this moment we have the possibility to evaluate the results in more than 5,000 cases. In one of the first papers of this experience published in 2010 by my colleagues Giacomo Novara in the European Urology about the validation of the 2009 version of the TNM messaging system, we noted that histologic subtypes turned out to be an independent predictors of cancer-specific survival at multivariable analysis, and therefore this observation supported our conviction and our idea that renal cell carcinomas are different types of tumors with different morphology, with different molecular characteristics, and at the same time with different cytogenetic findings. And this concept is always present and is considered also when we look at the different response of these tumor histotypes for medical therapy, and usually the most important guidelines like NCCN consider papillary RCC in the big folder of the no clear cell histology, but we must pay attention when we put together all the different tumor histotypes in the no clear cell folders, because as you can see in this slide, we have chromophobe RCC, papillary RCC, but also unclassified and Bellini tumor with prognosis significantly worse in comparison with papillary and chromophobe histological subtypes. And the same consideration were from this paper published in 2008 in the BJU International from Capitanio and co-workers. As you can see also in this experience, the survival of papillary RCC is in the middle between chromophobe and clear cell RCC. And again, when we look at the most important paper published in the literature in this field, we can observe that the percentages of the 5-year cancer-specific survival is in the middle between the worst prognosis represented by clear cell RCC and the best prognosis represented by chromophobe. But I ask you to pay attention to these differences in the 5-year cancer-specific survival between these two studies, one coming from Mayo Clinic after slight revision process, and another one that is a multi-institutional study from European centers in which we observed a 5-year cancer-specific survival significantly lower, but without slide revision of the cases. And this is an important message because in these little studies published by myself in 2006, we demonstrated that for papillary RCC, the originally assigned cases, the cancer-specific survival is different in comparison with the cases assigned as papillary RCC after slide revision. And this is very important, above all, when we considered in the retrospective analysis cases observed and treated before 1997. And for this reason, we started with this study with a Saturn project, including cases observed and treated from 1997. And this is the publication in the BJU Urology about the prognostic factors in papillary RCC. Our task was to evaluate the prognostic factors in 577 cases observed in this multi-institutional experience. As you can see, looking at the characteristic of patient, we have a mean age of 62 years. The majority of these present showed asymptomatic disease, and we performed in 62% of cases radical nephrectomy, in 32 cases an elective nephron-sparing surgery, and in 6% of cases an imperative nephron-sparing surgery. But very important, when we look at the pathological characteristics of this tumor, we observed that 80% of the cases were localized tumors, and only in 10% of the cases we have patients with lymph node involvement or distant metastasis at presentation. And very important is that 30% of cases were grade 3 or 4 according to Fuhrman classification, and this patient can be considered as a type 2 according to the classification of the Lount and Ebel. And concerning oncological outcomes, in this experience we have a median follow-up of 39 months with 464 patients alive and disease-free, with a median follow-up of 42 months. 40% of cases had a disease progression, 11% of cases died for the disease, and 5% of the cases died for other causes not correlated with the kidney cancer. Looking at the recurrence-free survival, we observed a 5-year recurrence-free survival of 85.5% of the cases, and the 10 years recurrence-free survival was 73% of the cases. And when we analyze our data according to univariable and multivariable analysis, we showed that pathological T-stage was not statistically significant at the multivariable analysis, and only lymph node involvement and presence of distant metastasis and nuclear grading turned out to be independent predictors of recurrence-free survival in this patient. This is a very important message, above all for the TNM classification, because I am convinced that the majority of the information coming from the literature are coming from clear cell RCC, and perhaps our TNM system works very well for clear cell RCC, but probably the situation for papillary, chromophobe, or other tumor histotypes is completely different, and therefore this could be considered in the future. Other very important message is grade 1 and grade 2. As you can see, the survival is significantly different in comparison with grade 3 and grade 4 cancer. But the most important prognostic factors are represented by lymph node involvement. As you can see, patients with lymph node involvement at the diagnosis showed a 5-year recurrence-free survival of 26.8% of the cases, and also the patient with distant metastasis showed a similar 5-year recurrence-free survival. What's about cancer-specific survival? This is the survival curves showing the 5 years and 10 years cancer-specific survival, and at the multivariable analysis we had the same results that I showed before for recurrence-free survival. Again, the only difference is that mode of presentation turned out to be an independent predictor of cancer-specific survival, and as you can see, incidental tumor showed cancer-specific survival significantly better in comparison with patients with local symptoms, or above all with patients with systematic symptoms. Of course, our study had some study limitation. The first one is that this is a retrospective analysis. At the same time, we included data coming from 16 centers. Then this is a multi-surgeon series. The specimen was evaluated by multiple pathologists without slide revision, and the treatment for disease recurrences was not standardized. And again, without slide review, it was not possible for us to assign correctly the subdivision of the papillary RCC in type 1 and type 2 according to the Lawent and Ibley classification. And it seems to be that this is important according to this paper published by UCLA, showing that type 1 tumor is significantly better in comparison with type 2. But I would like to ask you to pay attention when we use this subclassification between type 2 and type 1, because looking at the literature, this subtyping remains difficult, and different percentages of type 1 and type 2 are reported in the published series. This means that it is very difficult for the pathologist correctly assign the type 2 papillary, and then we need to have very experienced pathologists to have correct evaluation of this parameter. Another important point that it was not evaluated in the Saturn project was the role of nuclear grade. In this publication, some pathologists support the use of the nuclear grading instead of the Foreman grade for papillary RCC. And in this more recent paper coming from the UCLA, Clayt and co-workers showed that nuclear grading seems to be more predictive in comparison with the nuclear grading, as you can see looking at the different values of the concordance index. Another parameter that it was not evaluated because was available only in a small percentages of our cases was coagulative necrosis. As you can see in the experience of the Mayo Clinic, coagulative necrosis for papillary RCC is not important. Vice versa, when we consider the experience of the UCLA, necrosis turned out to be in papillary RCC an independent predictors of cancer-specific survival. Then in conclusion, I think that this data can demonstrate that papillary RCC is a low-risk tumor recurrence and cancer-related death after surgery. At the same time, we must pay more attention for patients with papillary RCC with lymph node involvement and presence of distant metastasis, and above all for patients with grade 3 and grade 4 nuclear grading according to Foreman. More attention we must pay for the correct allocation of the subtype and sub 1 and 2 in this category of tumors, and I think that to have more and more information and to better identify the characteristics of this tumor, we must consider in the next future more studies including molecular and cytogenetic prognostic factors. Thank you so much for your attention.
I'd like to bring you back a little bit into the clinics, and the question is, why should we pay particular attention to a specific metastatic site like the bone? So, well, 1/3 of our patients will eventually develop skeletal metastasis from renal cell cancer, and as already shown today, the presence of bone metastasis has been associated with a poor outcome in renal cell cancer. Bone metastases were shown to be particularly destructive, and there are in fact higher rates of skeletal-related events in patients with renal cell cancer and bone metastasis than in patients who have bone metastasis from other tumors. And in particular, hypercalcemia appears to be a dramatic issue. This figure illustrates the survival of renal cell cancer patients with bone metastasis depending upon the type of first skeletal-related event. And what we can see here is that the curves are quite separated. And patients who develop as their first skeletal-related event hypercalcemia survive significantly shorter than those whose first skeletal-related event was surgery for bone pain. Despite the use of novel agents, bone metastases were shown to be associated with a poor outcome. So even now in the era of targeted agents, this is a PFS and overall survival analysis recently published, clearly showing a difference between PFS and overall survival in patients with or without bone metastasis. And interestingly, in this analysis, the presence of bone metastasis alone was shown to be an independent predictor of overall survival and of progression-free survival. I believe that these data clearly reflect an urgent need for an additional treatment for bone metastasis. So targeting the bone includes currently 3 strategies: drugs, surgery, and radiotherapy. Let me start with targeting the bone by drugs. So the development of anti-resorptive agents have really revolutionized the treatment of patients with bone metastasis and certainly have brought great improvement of quality of life. And here in particular, biphosphonates were shown to effectively inhibit osteoclast-mediated bone resorption. Is this irrelevant in patients with kidney cancer? It is relevant because subgroup analysis of large randomized trials in fact clearly showed that for the patients with metastatic renal cell cancer, these patients derive a significant benefit when compared to placebo. And the benefit derived from zoledronic acid was a reduction in the rate of skeletal-related events, an extension of the time to the first event, and a longer median time to progression of the bone lesion. However, the widespread use of biphosphonates in kidney cancer has been limited in the past by some adverse events, and in particular here, the potential toxicity of renal impairment that may arise from the use of zoledronic acid was a concern. And in addition, there is data that the osteonecrosis of the jaw, ONJ, may be exacerbated in patients who are undergoing treatment with anti-angiogenic agents. This is also a reason why regular dental examination is required. And while novel agents like denosumab appear not to affect in the same amount the kidney function, the overall incidence regarding the development of osteonecrosis of the jaw is similar to zoledronic acid. So when we look at the data we have in the clinics and regarding efficacy and side effect, we have to say that the clear benefits of zoledronic acid much outweigh the safety concerns. What are the potential advantages of zoledronic acid beyond control of bone metastasis, beyond induction of apoptosis in osteoclast and tumor cells? Zoledronic acid was also shown to inhibit tumor cell motility, adhesion, and invasion, to inhibit the growth of endothelial cells and the adhesion of endothelial cells, to inhibit angiogenesis-relevant kinases. In animal studies, significant reduction of the primary tumors were observed, a significant reduction of vessel density, immune-relevant functions, inhibition of visceral metastasis, reduction of tumor cells in the bone marrow has already been mentioned today, reduction of interleukin-6, which is a major driver of progression in kidney cancer. And all of these direct and indirect anti-tumor activities make it clear why zoledronic acid was able to significantly improve the recurrence-free survival and disease-free survival in the adjuvant breast cancer setting. This is the case of a patient of mine, a lady who was diagnosed with renal cell cancer at the age of 71. She underwent nephrectomy. 3 years later, she was diagnosed with a bone metastasis and with soft tissue involvement. She was an intermediate risk patient. I referred her to the surgeon. However, the surgeon said the resection is not feasible, so we included her first in a phase 2 trial on bevacizumab plus sorafenib, and in the same time we started treating her with zoledronic acid. We had to interrupt systemic treatment with sorafenib bevacizumab due to hand-foot syndrome. She received radiotherapy. Then we tried sunitinib, again here treatment interruption or discontinuation due to hand-foot syndrome. Temsirolimus next treatment, which at least provided a benefit for 17 months. We extended the treatment upon progression with temsirolimus and bevacizumab. And then she discontinued treatment due to a venous ulcer in September 2009, and then she only received zoledronic acid between September 2009 and her death in August 2011. I simply believe that this survival data achieved with, in this patient a survival of 52 months from the diagnosis of metastatic disease can also be attributed to the fact that this patient was treated with zoledronic acid. What about bone targeting? Here we have limited data available. A generous approach, however, to resection of metastasis appears reasonable in patients with good performance status. Why? Because bone metastases are less likely to respond to targeted agents, because bone metastases arising from renal cell cancer are more destructive, because resection may reduce the risk of impending fracture, and because in general resection of metastatic disease was shown to improve cancer-specific survival. So this is a retrospective analysis in 100 patients who were operatively treated for bone metastasis. And this analysis clearly showed that radical surgery can lead to durable long-term responses, in particular in younger patients without fracture and negative margins. We had a similar retrospective analysis carried out in our own department, where we could show that metastasectomy is an independent predictor of survival, and half of our patients underwent metastasectomy for bone metastasis. And finally, the role of metastasectomy in patients with various metastatic sites was also demonstrated in this recently published analysis, where it was clearly shown that with complete resection of metastasis, the 5-year cancer-specific survival rate is significantly increased. I'm less enthusiastic when it comes to radiotherapy. Bone metastases and you are aware of this, are less sensitive to radiotherapy. However, a palliative role is certainly here to reduce pain, to induce mineralization, and of course to treat nerve and spinal cord compression. There are few data on a potential synergism with zoledronic acid and radiotherapy and tyrosine kinase inhibitors. To summarize, bone metastases from renal cell cancer are particularly destructive and cause higher rates of skeletal-related events rather than bone metastases from other tumors. I strongly believe that a distinct attention to bone metastasis or to bone disease is required, since novel renal cell cancer agents may offer limited local benefits. Zoledronic acid was shown to reduce the rate of skeletal-related events and time to progression in renal cell cancer. The various attempts of zoledronic acid, anti-tumor effects of zoledronic acid, in particular the anti-angiogenic effects, I believe merit deeper investigation in renal cell cancer, not only in the palliative setting, probably also in the adjuvant setting. And despite the lack of prospective data, I also strongly believe that surgery has its merits and has repeatedly shown benefits in terms of overall survival. Thank you very much.